Positive end expiratory pressure or PEEP is the positive pressure that will remain in the airways at the end of the respiratory cycle, that means at the end of the exhalation. PEEP is not commonly regarded as stand-alone mode, rather it applied in the conjunction with the other ventilator modes. PEEP increases the end expiratory or the baseline airway pressure to a value greater than the atmospheric pressure, which is equals to 0 cm of H2O on the ventilator manometer. There are three major indications for PEEP. These are intrapulmonary shunt and the refractory hypoxemia, decreased functional residual capacity and lung compliance, and Auto-PEEP not responding to adjustment of ventilator settings. The primary indication for PEEP is refractory hypoxemia induced by intrapulmonary shunting. Refractory hypoxemia is defined as hypoxia that responds poorly to moderate to high level of oxygen. A helpful clinical guideline for refractory hypoxemia is when the patient's PaO2 is 60 mm of Hg or less at an FiO2 of 50% or higher. That means if any patient receiving oxygen with FiO2 of more than equals to 50% and after doing an ABG, if we get the PaO2 value less than equals to 60 mm of Hg, then we can say that the patient have refractory hypoxemia. This condition may be caused by reduction of functional residual capacity, atelectasis or low VQ mismatch. A severely diminished FRC and the reduced lung compliance greatly increases the alveolar opening pressure. Since the PEEP increases the FRC, this pulmonary impairment may be prevented or improved by early application of PEEP. Uncorrected air trapping may lead to Auto-PEEP. Now, where the air trapping may occur? These occur by severe airflow obstruction or insufficient expiratory time. Bronchodilator therapy and pulmonary clearance are helpful to reduce the airflow obstruction, and insufficient expiratory time may be corrected by increasing the peak flow, decreasing the frequency or decreasing the tidal volume. Work of breath triggering is increased by Auto-PEEP, as patient must overcome the Auto-PEEP level plus the sensitivity level to trigger the breath. For example, a patient has the Auto-PEEP of 6 cm of H2O and the sensitivity is set at 2 cm of H2O below the end expiratory baseline pressure. In this case, the patient would need to generate a total negative pressure of 8 cm of H2O, that means 6 cm of H2O for Auto-PEEP and 2 cm of H2O for the sensitivity. Auto-PEEP may be compensated by setting a PEEP level slightly below the Auto-PEEP level. By this, the end expiratory baseline pressure increases and this reduces the breath trigger effort. Normally, the alveolar end expiratory pressure equilibrates with the atmospheric pressure, that is 0, and average pleural pressure is approximately minus 5 cm of H2O. Under these conditions, the alveolar distending pressure is 5 cm of H2O. This is alveolar pressure minus the pleural pressure. If the force of elastic recoil is increased due to decrease in the compliance, the alveolar volume will decrease. If lung compliance continue to deteriorate, resulting in alveolar collapse and the intrapulmonary shunt. PEEP increases the alveolar end expiratory pressure, which decreases the pressure threshold for alveolar inflation. PEEP re-inflate the collapsed alveoli and support and maintain the alveolar inflation during the exhalation. Once recruitment of this alveolar occur and is sustained, PEEP decreases the threshold for alveolar opening and facilitate gas diffusion and oxygenation. Complications and hazards associated with PEEP include decreased venous return and cardiac output, barotrauma, increased intracranial pressure and alteration of renal function and water metabolism. When there is normal intravascular volume, venous return to the right atrium is influenced by the difference in the central venous pressure and the negative pleural pressure that surrounds the heart. During PEEP, the pleural pressure becomes less negative and the pressure gradient between the central venous drainage and the right atrium will decrease, result in the decreased venous pressure, result in the decreased venous return. This in turn results in the decreased cardiac output and hypotension. A given amount of PEEP does not impede venous return to the same degree in different patients. If the patient has extremely low lung compliance, the airway pressure is less readily transmitted to the pleural pressure. In contrast, if the patient has a normal or elevated lung compliance, the increased alveolar pressure due to the PEEP will more readily be transmitted into the pleural space. In other words, PEEP therapy in patient with normal or high lung compliance will more likely to produce an elevated pleural pressure and therefore decrease the venous return. But in case of low lung compliance, shields the pleural space from the full effect of increased alveolar pressure. Thus, despite high PEEP level, hemodynamic instability is not such a problem in patient with extremely low lung compliance, unless the patient has pre-existing cardiovascular disease. PEEP greater than 10 cm of H2O or mean airway pressure more than 30 cm of H2O or peak inspiratory pressure more than 50 cm of H2O is associated with an increased incidence of alveolar rupture or barotrauma. Alveolar rupture can produce pneumothorax, tension pneumothorax, pneumomediastinum, pneumopericardium, pneumoperitoneum. Subcutaneous emphysema or crepitus of unknown cause should always be interpreted as sign that barotrauma has occurred. In patient with normal lung compliance, PEEP may raises the intracranial pressure due to an impedance of venous return from cerebral perfusion. Normal intracranial pressure is 8 to 10 cm of H2O. Positive pressure ventilation can reduce the blood flow to the kidneys and affect their normal functions. When perfusion to the glomeruli of the kidney is decreased, filtration becomes less effective. Subsequently, the urine output is decreased as the kidney try to correct the perceived hypovolemic condition by retaining fluid. If the hypoperfusion of the kidney persists, renal failure may occur.